Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guests today are Dr. Brandon Gumbiner and Dr. Beth Reittinger. Dr. Gumbiner is the Residency Director of Podiatric Surgery at Catherine Shaw Bethea Hospital in Dixon, Illinois. Dr. Reittinger is a third-year resident in his program, and on today's episode, we will discuss the complexity and nuances of tarsal tunnel surgery and revision tarsal tunnel surgery, a most complex thing indeed. In this discussion, we take a really deep dive into what I consider one of the most complex lower extremity peripheral nerve surgeries that there is. I know that if you have any interest in tarsal tunnel syndrome, you will find this episode very valuable and informative. We also have the fortune and luxury to have my nerve fellow, Dr. Reittinger Nagra, join us in this entertaining discussion. Without further introduction, I hope you enjoy this one. All right. Is it getting cold up there?
Yes.
Yeah.
It is.
Yeah. Have you had any snow yet?
A little bit, nothing much that has stuck.
Okay.
But it's supposed to, temperature is really going to drop here in the next couple days. Are you guys getting tornadoes down there?
We haven't had any. We've had some high winds, but no tornadoes. So, well, I'm anxious to hear about this case. So,
Yeah. So you guys can see the screen?
Very good. Yes.
Okay. So back in May of this year, Dr. Gumbiner had a 45-year-old female present for a second opinion. Another podiatrist back in December did a tarsal tunnel release and plantar fasciotomy. And then she has been having issues since. She described having a running subcuticular with what sounded like proline, and then said when that was pulled, the incision dehisced. So then the same podiatrist did a elliptical excision with repair to the tarsal tunnel in March. And then that incision also ended up dehiscing. She continued to have hypersensitivity over the scar. When she first came to us in May, her pain was 4 out of 10. And she was told by the other podiatrist that she's just allergic to Vicryl, and that's why she's having multiple issues. But she didn't have any reaction to her plantar fasciotomy incision. So treatments since included prednisone, Keflex, and Bactrim with no improvement. She was also seen at that other podiatrist hospital wound center, and they applied a silver dressing, which caused significant increase in her pain. So she's, until now, continues to have hypersensitivity along the scar. She did not have feeling to the bottom of her foot until about 3-ish weeks ago. She had occasional burning and tingling and some shooting sensations, but only along the scar, and it seemed much more superficial. She was very frustrated and said it was causing her to become depressed, and she just wants her life back. And she's very frustrated with the lack of progress. So when we first started seeing her, we prescribed 0.05% clobetasol cream and then had her alternate one application daily every other day with Mederma scar cream. We had her do physical therapy for desensitization and manual deep tissue massage for mobilization of the scar tissue. And then we have pretty much extensively with every visit discussed in detail the possibility and concern that the tarsal tunnel is still entrapped, either from failure of full decompression or secondary to scar tissue she's developed since the 2 surgeries. And until recently, they just seemed to be more superficial. So this was the picture you see is last Tuesday.
Okay.
She has had wound issues since basically the first surgery, and it will heal and then it'll open up again. And so initially, we did ever see a dermatologist as well, who really only recommended applying Vaseline to the scar. So she's going on a really long trip hiking with her son for his graduation next summer. She really wants to be back as healthy and active as possible by then. Because she still only had issues basically that are superficial to the scar, we had scheduled her for excision of atrophic scar with rotational skinplasty, told her to follow up, and we scheduled her back in the beginning of October. Said, please come back and see us if anything changes. Well, things did change. She didn't tell us. We found out last Tuesday in day surgery, so pre-op, that she's been having shooting pain similar to her initial tarsal tunnel symptoms prior to her first surgery, and that's been going on for about 3 weeks. She does now have provocation points, approximately 12 centimeters proximal to her medial malleolus, and then where the medial and lateral plantar nerves branch near the glabrous junction. And so we canceled the case last Tuesday. We did order new EMG NCV, which we don't have the report yet, and we're planning to do a revision tarsal tunnel.
This is a tough case, isn't it?
Yeah. So I'll just set it on that.
Yeah. So she's still having drainage out of this incision, is what you said?
She did so when I first saw her, which was about 6 weeks after her second surgery, which was just a scar revision, right? She was having drainage. When we gave her the clobetasol and Mederma, it actually resolved the wound and resolved the drainage. And she was actually pretty optimistic at that time because therapy was helping. And I had actually thought, well, I think we've managed this conservatively.
Right.
And she disappeared for most of the summer and then came back, I think August or September, somewhere in there, and said that she would occasionally get drainage. However, we did not see it visually. Right. And that the skin would break down, but she had pain, and we did our neuro exam every time, and she said, no, it's very much the scar. It's very much the scar that's bothering her. The symptoms of the tarsal tunnel were gone. And I said, okay. But then this time. So currently, no, it is not draining is the answer to your question. Yeah.
Yeah. So, so she really only had one tarsal tunnel surgery. The second surgery was just a scar modification.
That's correct.
Okay. It's hard for me to see on this picture, but it looks like that scar at the distal aspect is kind of going over the medial plantar tunnel, right? Mm-hmm. Versus, it'd be hard for me to imagine that they could get the lateral plantar nerve tunnel from that scar completely decompressed. Is that kind of correlative with what you all see?
I would agree. This other surgeon, I know him, and I've operated with him in my training, and I know how he does these procedures. He does not dissect out those nerves. Okay. So I would.
He doesn't. So what you're saying is he's not really doing anything, in the medial and lateral plantar nerve tunnel. It's really more just a proximal release.
Correct.
Yeah. So,
and I'm sure he's not going high enough either. I'm sure of that too.
Well, and you made a comment there that there was a provocation sign, 12 centimeters, 15 centimeters proximal to the medial malleolus. So almost in your, like where the tibial nerve comes out from the deep posterior compartment, the gastroc, medial gastroc soleus junction in that area, which is, one of the sites that, that and the soleal sling more proximal can give you the two proximal entrapments. So, when I first heard, from Dr. Nagra about this case, it was like, wow, going back in on tarsal tunnels, the least favorite thing that I can do, especially in a patient that has wound healing considerations, that type of thing. Have you given her a block up by the distal gastroc soleus junction?
We have not.
Okay. So, based on the incision placement and her symptoms, it appears that she still has, definitive nerve entrapment, probably very definitely of the lateral plantar nerve tunnel, but probably also the medial because of you knowing the history of the other surgeon not releasing those tunnels. So you're almost obliged to have to, to do that. So the one thing is that your lateral plantar tunnel could almost be like a virgin tunnel there. Even though it's a revision surgery, it could almost be, pretty good tissue to deal with. It's hard to it's hard to go back in on a case in somebody that's had such a wound healing problem too, because if it's poor tissue and there's another wound healing problem, what prevents you from having the fibrosis post-operatively? I mean, you can do a perfect revision, and then you can still end up with the same problem. So this is not an easy case. You also mentioned that she's having some depression, I think. So that makes it even, puts this into another higher level category of difficulty because, and I'm not saying that, that would preclude me from addressing this, but it's something that might be better to address before you revise it than after. I mean, is she taking antidepressants? Has she had a psychological consultation, psychiatric care?
She does have a history of anxiety and depression. So I'm sure that is, I don't know exactly what she's on currently. I just did a write-up for her last week, but I think it's just heightened and worsened since her activity has not progressed back to normal like she was expecting.
All of the sponsors of this podcast are listed on the website at podofinquiry.com. You can get great offers on these fantastic products and services, and this will help generate revenue for the show, so that we can bring you the absolute best content. Thank you all for listening and supporting the show.
Several years ago, I chose Alpinion as my ultrasound brand of choice after years of experience and research into ultrasound imaging. In fact, I have 2 of their machines. Alpinion has incredible precision and penetration built into their technology that, in my opinion, is simply the best value in all of the ultrasound imaging space. They have several price points to meet your needs, and I can tell you definitively that you'll end up having to pay double to achieve the equivalent imaging quality from other top brands. That doesn't even account for the unlimited software updates and remote tech support included with no monthly fees. Right now, to show their appreciation for the listeners of the Pod of Inquiry, they're offering an incredible discount. Their portable i7 retails for $21,000. But you can get it discounted at most medical meetings for $19,000. But my listeners will get it discounted to $15,900. This has never been offered anywhere for the new portable system with the engine of a console system. Use code SBPOI to take advantage of this incredible offer. You won't be disappointed with Alpinion. I sure haven't been. Yeah, I think one thing that may help you all is to get a psychiatric consult on her and get her dialed up as much as possible, because regardless of what you end up doing, it's going to take her out of the day-to-day. And if she's been hiking and using compression and doing you're still going to have some, I think you would be extremely lucky for her not to have another episode of anxiety and depression. I think that's just part of the normal progress of these patients. And Beth, to your point about the anxiety and the depression, they're inextricably woven together. And it's really, some of the psychiatrists that I've worked with feel it's one and the same. That, I think the one thing that I would do is probably get a psychiatric consultation, because you want to maximize her as much as you possibly can from that standpoint, as well as just getting her in the right mindset can help a lot. The other thing you have to take into consideration is how much proximal entrapment is leading to this. And, depending on the circumstances, it may be a case where you look at it proximally and you maybe think about breaking this into two components. And I would say that I wouldn't stage it necessarily unless I saw something pretty dramatic with a diagnostic lidocaine block up more proximal at that area. But let's say you put in, a sub-anesthetic dose of lidocaine, a half a cc or something under ultrasound guidance proximally, and see what happens. If she gets a good response with that, you may want to say, listen, it'd be a lot safer for us to go up proximally and decompress that tibial nerve farther up. We may still have to go farther down south, so to speak, because we really feel that you do have a lateral plantar nerve component, possibly a medial plantar nerve component, but at least you're taking that one thing off the table that may give her the benefit. That's going to be predicated on her response to that. But the other thing that may be very worthwhile, and it wouldn't put you in a box at all, is if she's willing to stage that, because I think psychologically for her, the wound healing is probably as big of a component as some of her neurological symptoms. I don't know. Would you think that'd be fair assessment?
No, I think so. I think, she's been so focused on the wound. I mean, that's really why we scheduled her to do a tissue transfer there.
Right.
And I sort of wondered, I mean, when we walked in to sign the leg the morning of surgery, and she started saying, now I'm concerned because all these symptoms have come back. There was a component of it that I felt like, well, is she just really anxious about surgery, that she's hypersensitive to it? But then when we evaluated her and did another neuro exam, we realized, no, there's probably residual entrapment.
Yeah. Well, I don't doubt that there is. And, some of it is probably, from the previous surgery and the wound, the wound issues as well. But wouldn't it be great if you could just go up proximally, decompress it there, and maybe put in a peripheral nerve stimulator at the same time, because that's going to give you that added layer of protection if you do have to go back. And, so I mean, this would be a patient that I would manage in a serial manner. And the first thing I would do would be not to go down into that previously operated area. And if you do have to do that on a second surgery, well, her mind's now more adjusted to it. You've taken some stuff off the table with the proximal entrapment, and you also have your peripheral nerve stimulator in place. So that may, mitigate her post-operative, pain management issues. If you did have to go down and do a more distal decompression. Mm-hmm. And, no one, I wished I had the crystal ball, but I would say the thing to do would be definitely look at that nerve block and see how that works for her. And, it might be the case where if you get enough, and maybe, in addition to the nerve block, do a stim trial on her. Mm-hmm. And then that way, if the stim trial works really well, that's the answer. And then you don't have to go into that area of where you've got that pseudo viable tissue.
Mm-hmm. What would you do about the scar, Dr. Barrett? Because I think you're right. I think that is a component of it. She'll want that managed. Would you just do a little rotational skin flap there and keep it superficial?
If it's not draining a lot, I would probably leave it alone for a while. And if you, believe it or not, if you sometimes take care of the neurological stuff, there's this improvement in the overall homeostasis of the tissues. It's crazy how things will, but it's not infected now. It's not, apparently draining, even though she says that it does occasionally. Yeah, I would probably try to not poke that bear right now and go more proximal. I think, especially if you get a good result with the stim trial. If you do a stim trial on her and she says, oh yeah, it's like 50% or more improved, then I would think that is a lot of justification to go proximally. And Dr. Ellison's shown, with the proximal decompressions, that a lot of times the distal decompressions, without addressing them, get better. They're there, but you're not addressing them. But it's kind of like the double crush, situation, or triple crush. You take one or two of the proximal away, then the distal can function okay. I just really hate these types of cases because they're very difficult. You can do the most perfect job and you still get stuck.
Yeah.
And I think if you explain everything that we've just kind of talked to her, or that we've talked about to her, it would surprise me if she wasn't willing, based on the clinical, how she responds to the stim router or peripheral stimulator, and how she would respond to the block. You'd have to do those separate, of course. Well, I guess you could do the stim trial first, and then you could block her after that. Could do it at the same time.
Okay.
Does that sound logical?
Yeah, no, it makes a lot of sense, and it's helpful too. I mean, yeah, I don't really want to have to cut back through that tissue.
Right.
If we don't have to.
Yeah, it's all already kind of pseudo viable, and I don't know that was necessarily a vicral issue, or that's an area that there is a high preponderance of dehiscence. And, if there's any venous insufficiency, which looks like she has a little bit of venous insufficiency in that extremity, those are things that definitely go against you for sure. What's her other leg like? Any similar symptoms?
No.
Okay.
No, she's on that side. I mean, I don't know. I kind of question whether or not, I don't know, the original surgery, if she actually had tarsal tunnel at the time or not. But
yeah, well, it's hard to say. And they did a fasciotomy at the same time with this.
Yeah, separate incision planarly.
Okay,
from medial to lateral.
Yeah, I think you can see that.
The
medial right here.
Right. Is her heel pain better?
Yeah, she doesn't complain of any heel pain.
Okay. All right.
And even when that first visit with her, she goes, no, the surgery resolved the pains that I came in for.
Right.
It's just that at the time I saw her, it was the dehiscence that was the problem.
Yeah. And that maybe bodes well too for what we're talking about. Maybe, you don't create another wound that doesn't heal and you get it, you circumvent it from a proximal intervention. That could be the best thing for her. I mean, you can always go back if you have to, but man, like you say, making an incision in that area, it's tough.
Yeah. No, I agree. And yeah, especially cutting all the way down to the nerve again. I mean, I feel like, and that's why Beth and I were talking about it. I said, I feel like we're just asking for trouble.
Yeah. Yeah.
So.
No, I think you guys made a really smart decision, and kind of like rebooting and rethinking this. I mean, this is a chronic problem for this patient, and it's something that you have to enter into with the highest amount of judiciousness that you possibly can. And even if everything goes perfect from a surgical standpoint, it still doesn't, say, all right, she doesn't get another wound dehiscence. So, and if you get another wound dehiscence in that area, then you're going to have more fibrosis, and that's going to maybe lead to further nerve entrapment as well.
Yeah.
I would like to hear back on this case. It's a very interesting case. I'd love to see how she does with the stim trial and with the blocks. I think this is it's a case, unfortunately, I see way too many of. And I think the one thing it definitely proves is that there is no such thing as routine tarsal tunnel surgery.
Right.
Yeah. It's kind of like routine alligator wrestling.
Yeah.
Yeah. Yeah.
Just one thought that I had, Dr. Barrett, is if they do the stim trial, let's say it doesn't go as well as we think, and they have to do a revision surgery, it'd probably be a good idea to also put a pain pump.
Oh, yeah. Yeah, you probably would want to do that. But, sometimes then pain pumps I've seen, because they keep it too macerated, lead to more wound issues. So that's another thing to have to debate. But yeah, pain pump maybe more proximal, like way proximal rather than distal. I don't know. I think before you come to judgment, I'd do those additional clinical tests and see, and then you'll be a little bit more, I guess, clear in what you want to do.
Okay. I think that's very reasonable. I really appreciate the input.
Yeah. Thank you so much.
Yeah. Well, I wish you never had to see cases like this, because they are really a problem, So let's get back together though, and talk about what you find with the other. I think I think this is a very educational case, and that's why I wanted to kind of capture this so, people can learn. This is how, this is really one of the greatest educational tools here, is real case examples.
Yeah.
Yep, I agree.
Yeah, sounds good. We'll touch base again then.
All right.
After we come back.
All righty, guys. Well,
all right.
Speak to you. Have a great holiday.
Thank you, you too.
Yeah, you too.
All right.
Thank
Be
you
well.
both.
All right.
Bye.
Bye-bye.
Thank you.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.